I was having coffee recently with an old friend, one of those people who is completely obsessed with self-optimization. He tracks his sleep cycles, he invests in longevity tech, and he practically worships the concept of extending his health span. He is, by all accounts, the last person you would ever associate with the idea of giving up. He loves life almost aggressively. But when the conversation drifted toward the recent legal changes, in places like Canada and the Netherlands regarding assisted dying, the whole atmosphere at the table it shifted instantly. He didn't get uncomfortable or change the subject. Instead, he leaned in with this intense, almost clinical fascination. He looked me dead in the eye and said, "I don't want to die. I just want to know where the fire exit is." And he explained it with this strange, paradoxical logic. To him, the party's only fun if you know the doors aren't locked from the outside. He argued that the moment society compels you to remain alive against your will, you stop being a guest in existence and you start becoming a prisoner of it. That distinct shift from a man obsessed with prolonging his life to suddenly arguing so passionately for the right to end it was jarring. It wasn't about despair or depression. It was about something much more primal: control. It made me realize that his obsession with the right to death wasn't a rejection of the gift of life, but actually a desperate attempt to claim ownership over it. And it forces a terrifying question. If we aren't allowed to leave the room, can we ever truly say we chose to be there?
That concept, the fire exit of radical autonomy, it's profoundly unsettling. Because as you just identified, it shifts the entire conversation. We're no longer just talking about addressing pain and suffering. We're talking about redefining human value itself.
Exactly.
And you've really hit on the central tension of this deep dive. It's this ultimate assertion of individual control over mortality versus, all the structures and norms and institutions that have historically held society together.
Things like the family, the medical profession, the state itself.
Precisely. So our objective today is to rigorously analyze this push for radical autonomy. We're going to look at it through the lens of the critics, those concerned about the erosion of social cohesion, the collapse of what's called the sanctity of life doctrine.
And this is the really surprising part.
And the growing reach of institutional and state power that, ironically, is what facilitates this ultimate individual freedom.
So we're diving into the argument that this pursuit of absolute self-determination in death, this ultimate liberty, might be, I guess, inadvertently dismantling the very things that give life security and meaning, and in the process, granting vast, unintended power to the state and its agents.
That's the mission. And I think we have to start at the bedrock of this debate. We have to look at the profound philosophical principles that are being systematically challenged by the legalization of assisted death. So for centuries, the ethical foundation of really all of Western law and morality has been built on one core principle:
the sanctity of human life.
Sanctity of human life. And this isn't just a religious concept. People often misunderstand that. It's a foundational ethical doctrine. It maintains that every single human life possesses intrinsic, immeasurable dignity and worth.
And that worth exists regardless of anything else.
Regardless of physical condition, cognitive ability, age, or, your ability to contribute to society. It's the core reason the law places an absolute unwavering prohibition on the intentional killing of the innocent. Full stop.
And what makes that doctrine so absolute is that it prohibits intentional killing regardless of the motive. So even if the motive is compassionate, to alleviate suffering, the act itself is still prohibited.
Correct. The core function of the sanctity doctrine is to protect the weakest members of society. It does that by removing the ability of anyone, a physician, a family member, the state, to make a judgment call on whether that person's life is worth living.
Which immediately clashes with the modern discourse on assisted dying.
It clashes completely because that entire movement is fundamentally built on what we call the quality of life philosophy.
And the quality of life approach that seems to hinge on the idea that the value of a life is contingent upon certain metrics. It's like there's a threshold of function or dignity or capability you have to meet.
It does. It determines whose lives are worthwhile based on criteria that critics would argue are fundamentally arbitrary and subjective. The moment you transition from recognizing the intrinsic worth of all life to assessing its instrumental value based on quality, you open the door to all kinds of discriminatory judgments.
Against those who are suffering, disabled, or reliant on others.
Exactly. We see this danger highlighted in legal analysis. Justice Neil Gorsuch, for example, he noted that in jurisdictions like the Netherlands, the official justification for killing often rests on a physician's assessment that the patient's quality of life is degrading, deteriorating, or hopeless.
That feels like the critical difference, right?
Yeah.
In the sanctity model, the suffering is the problem you're trying to solve. But in the quality model, the suffering life becomes the problem to be eliminated.
That is precisely the shift. And that assessment degrading, hopeless, is deeply subjective, which means it is incredibly susceptible to institutional bias. The moment the law sanctions intentional killing, even under the banner of compassion, it ceases to protect all innocent life equally. It essentially creates classes of life that are, well, legally disposable. We also have to underline this essential legal distinction. It's one that's been upheld by courts, including the U.S. Supreme Court, and it's key to maintaining that sanctity framework. And that is allowing someone to die a natural death, often by withholding or withdrawing intrusive, useless medical treatment, is fundamentally and legally distinct from actively killing them or assisting their suicide.
Okay, help us unpack that distinction, because opponents often conflate the two acts. They argue that the intent is the same in both cases, to end suffering.
Well, the sanctity doctrine holds that the doctor's duty is always to care, never to kill. So when a doctor withholds a treatment that's deemed burdensome or medically useless, the underlying fatal illness remains the actual cause of death.
I see. So the focus of the decision is always on whether the treatment is worthwhile, not whether the patient's life is worthwhile.
That's the crucial point. In contrast, when a doctor administers or prescribes a lethal drug, the doctor becomes the agent of death. It is an intentional act with the singular purpose of extinguishing life, which is precisely what the Hippocratic tradition prohibits. And that boundary is vital because it protects the integrity of medicine as a healing profession.
Okay, let's connect this shift in philosophy to the discussion of human dignity and equality before the law, which is a major focus in our research. Critics argue pretty vehemently that classifying a specific disadvantaged subgroup of people, like the terminally ill or, increasingly, the severely disabled, as legally eligible to be killed fundamentally violates their intrinsic human dignity.
This is a powerful critique, and it's voiced particularly by the disability rights community. They argue that these KAS laws establish a deeply corrosive double standard.
They deny equality before the law.
They absolutely do. Think about it. If an able-bodied person expresses suicidal thoughts, society and the law mandate intervention. We provide counseling, psychological support, suicide prevention.
But for a disabled citizen facing that exact same desire to die, the response just pivots entirely.
It pivots from prevention to facilitation. The law effectively permits the physician to assist the suicide because the physical dependence or the disability itself is implicitly viewed as depriving the individual of autonomy and dignity. So the law is essentially sanctioning the idea that a life with a disabling condition is, for all intents and purposes, not worth living.
Which justifies treating that disabled person completely differently than you would an able-bodied person with suicidal thoughts. That structural inequality makes the right to die look a lot less like a movement for liberation and more like an institutional endorsement of discrimination against the most vulnerable. And philosophically, the very concept of a right to die is questioned as being, well, nonsensical.
Many philosophers argue that the notion of a fundamental right to self-destruction is just incoherent and nihilistic, at least within the classical Western framework. They see this contemporary movement as a profound shift from liberty to license.
And in the classical liberal tradition, liberty was understood as, what? Self-directed action in accordance with moral law, respecting the rights of others and your duties to the community.
Exactly. And license in this context.
License is defined as self-destructive action, or action that fundamentally debases one's own being, which also harms the community as well.
Right. And the argument is simple. The function of government, if you derive it from concepts like the Declaration of Independence, is to secure the inalienable right to life. So how can that same government simultaneously secure a supposed right to self-destruction? Liberty seeks to fulfill life. License seeks to extinguish it. The pursuit of ownership over one's existence, your friend's fire exit, requires eliminating the very foundation of existence itself. And critics suggest that's a philosophical dead end.
Moving from the philosophical to the professional. This tension seems to manifest most acutely in the field of medicine. If the goal of medicine is to heal and make whole, how does the legalization of physician-assisted suicide fundamentally corrupt that professional commitment?
It transforms the healer into what critics call a technical dispenser of death. And that's a violation of medicine's core commitment, which is historically documented in the Hippocratic Oath. It explicitly states, "I will neither give a deadly drug to anybody who asked for it, nor will I make a suggestion to this effect."
And the American Medical Association's Code of Ethics has consistently rejected PAS.
Consistently, stating it is fundamentally incompatible with the physician's role as healer.
But it's not just a matter of professional guidelines, is it? It's about the fundamental trust in the doctor-patient relationship. What happens to that relationship when death becomes just another standardized therapeutic option?
The trust is irrevocably damaged. Once killing is accepted as a routine management option, the professional formation and conscience of doctors are inevitably altered. The doctor risks losing that essential, undivided commitment to the life and health of the patient, regardless of the circumstance. We found a very powerful anecdote from a hospice physician who explained that he was only able to fully enter into caring for his dying patients precisely because he knew he could not and would not kill them.
Wow.
That absolute boundary, ironically, allowed him to offer unconditional care and presence.
That's a really profound insight. The inability to kill is what enabled him to care fully. So if that boundary is removed, the patient is almost forced into a defensive position. They can no longer speak freely about their suffering or their fears or their wish to not be a financial burden without this anxiety that their physician might interpret those words as a request to be killed.
Absolutely. The physician risks internalizing the suffering as a demand for death, and the patient risks fearing that their physician may encourage their death, particularly if the patient is elderly, disabled, or economically disadvantaged. The vocational commitment of doctors is to care for all people without questioning whether any individual is worth the effort. PAS laws require doctors to step outside that commitment and make that lethal judgment.
Okay, let's transition now from the abstract ethical collapse to the concrete social impact. If the goal of the fire exit is to assert radical individual freedom, the critique argues that the mechanisms to achieve this freedom impose immense unintended burdens on social cohesion, especially for the vulnerable.
That's right. The New York State Task Force on Life and the Law, way back in 1994, reviewed this comprehensively, and they reached a near unanimous conclusion. Legalizing assisted suicide and euthanasia would pose profound, disproportionate risks to marginalized populations.
So the poor, the elderly, members of minority groups.
And those who already struggle with inadequate access to comprehensive medical and palliative care, yes.
The logic seems to be that those whose lives are already compromised by systemic issues, poverty, lack of resources, lack of good insurance, they're the ones who will face the greatest pressure to use the option of assisted death.
Precisely, because the task force noted that the supposed clinical and legal safeguards, the ones designed to prevent abuse and error, are most likely to fail in exactly those marginalized situations where effective control is already compromised. And what we see in practice often confirms this concern, particularly regarding the risk of non-voluntary pressure, which of course undermines the entire premise of radical autonomy.
The studies on this are pretty revealing, especially when it comes to family dynamics. We found data from Oregon that showed a staggering, 40% of patients who used physician-assisted suicide cited being a burden on their family, friends, or caregivers as a primary motivation.
That statistic is chilling. It's chilling because it highlights the erosion of the interdependent life. PAS relies on a radical, atomistic individualism, where your ultimate duty is defined as not inconveniencing others. But critics argue that this contradicts the very nature of family life.
This brings us to that famous philosophical counterpoint by Gilbert Meilander. He addressed this dynamic in his essay, I Want to Burden My Loved Ones. What was his core argument against this idea that avoiding burden is the highest moral duty?
Meilander argued that to be burdened is central to true belonging. Family life, and really all of civilized social life, is fundamentally defined by the intergenerational responsibility to share life's struggle.
To shoulder one another's burdens?
Yes. Whether that is a parent caring for an unruly child or children caring for an aging dependent parent. When the law frames physical dependence as a deprivation of dignity that justifies death, it completely undermines that reciprocal, sacrificial duty.
So the message the law sends, that a life of dependence is a life not worth living. It doesn't just influence the patient. It influences the family members, who may start to view their elderly or disabled loved one as a burden, and then subtly, or maybe overtly, encourage them to take the fire exit.
The societal message increases the temptation for family members to view the dependent person as an obstacle to their own autonomy or fulfillment. This breaks down social solidarity and replaces unconditional care with a kind of contractual utilitarian relationship, where the inability to contribute or be independent just voids the contract. And beyond the familial and social pressures, the legal framework introduces profound and very direct perverse financial incentives into healthcare. This is a critical point that transforms the fire exit from an existential choice into a simple cost-saving measure.
It's pretty clear that assisting in a suicide, just prescribing a lethal dose, is almost always the cheapest option compared to providing comprehensive long-term palliative care or pain management or extensive specialized treatments. How stark is that contrast in actual institutional behavior?
It's stark enough to cause public outcry. We can look directly at the specific case in Oregon, the state that pioneered PAS. In 2008, the state-sponsored health plan, the Oregon Health Plan, denied coverage for expensive but medically recommended cancer treatments for several patients.
Okay.
But what did the plan offer instead? It offered to cover the cost of the lethal suicide drugs.
Wow. So that's not a subtle hint. That is a direct institutional decision that presents two options: a prohibitively expensive path to continued life, or a covered, state-sanctioned path to death.
That system forces the patient, especially the economically vulnerable patient, to weigh their right to life against the financial stability of their family or the expense to the state. It transforms the patient's perceived right to autonomy into a tool for institutional cost control.
And this systemic preference is underscored by the demographics in Oregon, right? The data consistently shows that over half the patients who used assisted suicide relied on government health coverage, Medicare or Medicaid.
That demographic dependency strongly suggests a dangerous convergence between public financing policies and the facilitation of patient death. It's exactly as critics warned the New York Task Force decades ago. They predicted that under any system, it would be far less costly for the state to administer a lethal injection than to care for a dependent patient through a prolonged dying process.
And once that financial dynamic is established, the physicians who are acting as gatekeepers are operating under the umbrella of a system that subtly, or not so subtly, incentivizes the cheaper option.
Which brings us to perhaps the most concrete empirical argument against legalization: the international experience. This is often called the slippery slope, which suggests that once the principle of judging lives is accepted, the practice becomes impossible to contain within strict legal boundaries.
The original proponents of PAS always promised that the legislation would be narrow, limited to the terminally ill, protected by rigorous safeguards that required explicit repeated requests. Have the jurisdictions that adopted PAS actually managed to keep those promises?
Categorically, no. We can look primarily at the experiences in the Netherlands and Belgium. In the Netherlands, Professor John Kuhn investigated the guidelines and found that key requirements, like the need for an explicit and persistent request from the patient, have been violated widely and with virtual impunity. Crucially, the sources show the sheer scale of the practice. In one survey from the 1990s, the total number of life-shortening acts whose primary intention was to kill reached over 10,000 in a single year.
10,000.
10,000, demonstrating that the practice extended far beyond the narrow PAS rules.
So the legal safeguards failed because the underlying logic driving the practice just proved to be inexorable. I mean, if compassion justifies a lethal prescription for a patient who requests it, what argument prevents extending that same compassion to a patient who is suffering but is incapable of requesting it?
That is the essential lethal logic that drives the expansion. The moral reasoning becomes impossible to halt. If we accept the premise that suffering justifies the termination of life, then why on earth should we deny that benefit to someone who is too demented, too disabled, or too young to make that request? Dr. Ezekiel Emanuel, a prominent bioethicist, noted that the persistence of abuse and the violation of safeguards in the Netherlands suggest that the feared consequences of legalization are, in fact, the inherent consequences of the principle itself.
Which means extending the practice directly to non-voluntary euthanasia. And the sources detail the ultimate extension of this logic, which is frankly shocking: the non-voluntary euthanasia of disabled infants.
Yes. In 1996, Dutch courts acquitted doctors who performed non-voluntary euthanasia on disabled infants. The court justified the action based on medical necessity. The court reasoned, building on the logic of PAS, that if necessity justifies ending the life of a suffering patient who can request it, it equally justifies ending the life of a suffering patient who cannot.
Wait a minute. The court reasoned that medical necessity justifies ending the life of an infant who cannot request it. That seems to shatter the fundamental premise of consent that the entire PAS movement is supposedly built upon, this idea of radical autonomy. How did they bridge that ethical gap?
They bridged it by prioritizing the subjective quality of life judgment, the child's perceived future suffering and degradation over the legal and ethical requirement for consent. Following that ruling, Dutch pediatricians actually developed formal protocols, like the Groningen Protocol, that laid out criteria for performing an infanticide. The trajectory, which has been documented empirically by these countries, is absolutely clear. It moves rapidly from physician-assisted suicide to voluntary euthanasia, and eventually to non-voluntary euthanasia for the incompetent, the severely disabled, and infants.
This international evidence of expansion brings us back to the great paradox of the fire exit. The initial motivation for this movement is radical individual liberty, the freedom to choose the time and manner of one's death. Yet the mechanism required to enable that exit legalization, institutional authorization, and medical execution seems to empower the very state structures that radical individualists claim to distrust.
This conflict highlights a deep tension, even within classical liberal philosophy. We can look back at thinkers like John Stuart Mill, whose harm principle suggested that suicide itself shouldn't be prohibited. He reasoned that the evil resulting from it falls wholly on the agent. But Mill was very careful to concede that assisting suicide or engaging in consensual killing is a social act that undeniably affects others.
And is therefore amenable to social control.
Exactly. So even for a theorist deeply committed to minimizing state interference, assisting suicide crosses the line from a private act into a social act that requires or at least justifies legislative intervention.
Right. And the conclusion often reached by classical liberals and moderate conservatives is that preventing harm to the vulnerable and the community has to override the claim to absolute autonomy in this context.
Absolutely. It's also critical to remember the history of legal change here. When the UK decriminalized suicide in 1961, it was not an establishment of a right to die. It was a societal decision that suicidal people needed help, compassion, and mental health support, not criminal punishment.
But assisting suicide remained a very serious criminal offense.
A very serious offense. The focus was rehabilitation, not facilitation.
The moment you substitute that focus on prevention with a focus on facilitation, and you make the end-of-life decision contingent on a third party, the doctor, you immediately introduce the state's involvement through its authorized agents. This is where Thomas Saz's deep critique of the therapeutic state becomes exceptionally relevant.
Saz, the noted psychiatrist, dedicated his entire career to critiquing what he called the therapeutic state and pharmacracy. He argued that this is a polity where medicine and the state are subtly united and where official state force and coercion are justified using medical metaphors, often under the guise of care or public health.
And Saz viewed physician-assisted suicide as an evasion fatal to freedom. So if my friend wants the fire exit and he is healthy, he's committing suicide. Why does linking it to a doctor suddenly compromise his freedom?
Because it takes an ultimate existential choice, a profound personal decision, and makes it contingent on getting permission and lethal drugs from a doctor who is legislatively mandated to act as a gatekeeper of the state. Saz argued this transforms a deeply moral and personal decision into a matter of state-sanctioned medical control and bureaucracy. The individual seeking freedom must first submit their decision to institutional validation. This leads to Saz's powerful critique of the very terminology. He insisted that physician-assisted suicide is a deception. If the patient self-administers the lethal dose, it is simply suicide. The doctor merely provided the means. We don't say merchant-assisted suicide when a person buys a rope or a firearm.
Right.
However, if the doctor administers the drug, that is killing or euthanasia.
And the sources confirmed that the legislation authorizing PAS typically specifies that the act is not legally considered suicide. Why that specific legal maneuver?
It's necessary precisely to indemnify the actors. By classifying the act as a medical procedure performed under a controlled environment, the state can legally justify the death and grant the doctor immunity from criminal prosecution or civil liability. This language manipulation ensures that the choice remains under the control of the state's therapeutic bureaucracy, thereby reinforcing its power over the choice, even as it appears to grant individual autonomy.
That seems to be the very essence of the therapeutic state. Coercion and control masquerading as care.
Absolutely. The therapeutic state system classifies disapproved behaviors, even the choice to die outside of approved channels, as diseases or disorders, undermining personal responsibility. By giving physicians the inherently conflicting roles of both preventing suicide and providing it, the state turns doctors into covert agents of social control.
And this is the mechanism of pharmacracy.
Yes, the substitution of medical controls for traditional legal, social, or religious controls.
And we see this medicalization of life expanding everywhere, right? Far beyond end-of-life choices. Anxiety, dissatisfaction, even specific behaviors in children are all increasingly pathologized as diseases or disorders requiring some kind of pharmacological intervention.
That is the expansion of pharmacracy in action. Zaz warned that this subtle totalitarianism subtly reinforces the power of doctors, insurance companies, and the state. It replaces genuine individual self-control with legal and therapeutic sanctions. In this view, the individual is seen less as a private person with inviolable rights over their own body, and more as a piece of public property that has a duty to the community to be healthy and functional.
So the desperate search for the fire exit, that ultimate individual freedom, is betrayed. It requires the individual to submit to the ultimate institutionalization of the decision, giving state-sanctioned medical authorities the power to validate and facilitate that exit. The pursuit of self-determination ironically validates the state's claim to control existence itself.
The profound philosophical shift from the sanctity of life to the quality of life inevitably necessitated a legal revolution, particularly in how courts define personhood and human existence. And this revolution is epitomized by the endorsement of what's called dualism in certain key judicial opinions.
Dualism, in this legal context, views a human being as comprising two distinct entities, correct? A body and a person.
Precisely. The body is reduced to a mere biological unit, a shell of instrumental value, while the person is the valuable, conscious, sentient entity, the spirit or the self. This philosophical split allows legal actors to justify actions against the physical body if the person is deemed absent or irreparably damaged.
And this dualistic reasoning was starkly displayed in that landmark British case of Tony Bland, which dealt with the withdrawal of feeding tubes from a patient in a persistent vegetative state after the Hillsborough football disaster.
That case is the legal watershed moment. The judges were asked to approve the withdrawal of nutrition and hydration, an action that would inevitably lead to Bland's death. The language used by the judges clearly reveals the adoption of the quality of life standard, which is supported by this dualistic thinking. For instance, Sir Stephen Brown described Bland's continued existence as a humiliation, stating, "His spirit has left him, and all that remains is the shell of his body, which is kept functioning as a biological unit."
And another judge, Lord Justice Hoffman, used the phrase that Bland was grotesquely alive. The court was making a clear judgment that Bland's life, in its current biological state, was not only not worth living, but was an offense to human dignity.
That is the profound philosophical move. By reducing Bland's physical existence, the body, to mere instrumental value, the court essentially concluded that the valuable entity, the person, was gone, and therefore the biological remainder could be discarded.
This legal precedent denies the intrinsic worth of the human being
and replaces it with an implicit quality threshold for legal protection. Once you establish that a PVS patient can be killed because their body is merely a shell, critics warn that the door is open for that logic to extend to the severely disabled, the demented, or other groups deemed grotesquely alive.
So the dualism sets the precedent that physical existence is only valuable if it serves a certain level of consciousness or function.
Exactly. And even if we temporarily accept the logic of radical autonomy, the fire exit, the enacted legal frameworks designed to enable that choice fail drastically to sufficiently protect the patient's autonomy or prevent negligence.
The concern is that the statutory protections are illusory or just ineffective controls. Specifically, what makes the legal protections so ineffective in practice?
The statutory immunization of doctors is a major failure. The Oregon Assisted Suicide Statute, for example, is unique in how it protects physicians. It explicitly immunizes doctors from criminal prosecution, civil liability, or professional discipline for any actions they take in assisting a suicide, so long as they act in good faith.
That seems like a massive loophole. In virtually every other medical procedure, a doctor can be found liable for simple negligence, for malpractice. But here, in the most life-altering decision a patient can make, the doctor is protected unless their actions border on criminality, essentially by a good faith clause.
That's the problem. If a doctor misdiagnoses the patient as terminal or grossly misassesses their mental competence due to depression, there is effectively no legal recourse for the family or the patient because the law grants that protection. This failure to enforce standard legal accountability creates a vast space for negligence precisely where the stakes are highest. Furthermore, these laws often fail to ensure effective control over the patient at the most critical moment, the actual injection of the lethal drugs. Once the drugs are prescribed, there are often no mandatory safeguards to ensure the patient is mentally competent at the moment of self-administration. Nor is there a check to ensure they are not being pressured by family members to take the medication, perhaps in an isolated setting.
So if the ultimate goal is autonomous patient decision-making, as Judge Gorsuch observed, the regime utterly fails, because the moment of death itself, the moment of execution, is completely unprotected and unchecked by the state.
It creates a system where the right to die is prioritized and protected, while the right not to be coerced or killed is neglected. And there is a deeper cultural consequence here, which is the role of the law as a teacher.
The law sends a clear moral message, whether intentionally or not.
Absolutely. By classifying certain lives as not worth living and providing an official state-sanctioned route for their termination, PAS laws undermine the entire social culture. This message is internalized by everyone afflicted by suicidal thoughts or tendencies, including teenagers struggling with depression or the newly disabled. It tells them that, under certain prescribed circumstances, lack of function, dependency, terminal diagnosis, their life is in fact worthless. It confirms their darkest fears.
So, in accommodating the radical autonomy of a few, the specific desire for the fire exit, the law transmits a message that actively invalidates the lives of countless vulnerable people who should be receiving help, not encouragement to die.
That is the core conclusion derived from the legal critique. A legal framework that prioritizes the supposed right to die catastrophically nullifies the right not to be killed for many more people, especially the weak and the vulnerable. The introduction of this incoherent right compromises the legal system itself, replacing the natural right to life for all citizens with the selective allowance for self-destruction that operates under institutional control.
It sounds like the promise of ultimate individual control leads directly and tragically to an ultimate loss of collective security and the expansion of institutional power.
That is the inescapable paradox we have found in these sources.
So today we analyze the profound philosophical and social challenge posed by the right to death, which many proponents frame as the ultimate expression of ownership and control over one's existence, that psychological fire exit.
We started by charting the foundational ethical collapse, the destructive shift from the sanctity of life, the intrinsic worth of every human being, to the subjective and arbitrary quality of life standard. This movement systematically corrupted the role of the physician, transforming the healer into a potential dispenser of death, and eroding the vital, unconditional trust that sustains the doctor-patient relationship.
We then explored the critical social and economic costs, the undeniable peril to vulnerable groups, driven not only by familial pressure, where dependence becomes a moral burden, but also by perverse financial incentives, where death becomes the cost-effective alternative to compassionate long-term care. And the evidence from international experience confirmed that legal safeguards are incapable of containing the lethal logic, leading the practice to expand to non-voluntary cases, shattering the very premise of autonomy.
And finally, we connected this quest for radical autonomy to the threat of the therapeutic state and the concept of pharmacracy. The very mechanism required to authorize the fire exit, the involvement of physicians, insurers, and courts, transforms a deep personal existential choice into a regulated, medicalized, and institutionalized matter. The individual seeking freedom risks validating the expansion of state power over life itself, which operates through the guise of medical social control.
The promise of absolute self-determination in death is complicated by the fact that the legal and medical mechanisms required to grant that exit necessarily empower institutions, physicians, courts, and insurers to weigh and judge the value of the life being ended. This transforms a profound personal decision of mortality into a matter of state calculation, where the pursuit of the fire exit inadvertently validates the institutionalization of control over existence itself.